Hey everyone, this is Omar and Khatib, Director of Growth over at Potrero Medical. Thank you very much for joining us this morning. We have a very, very special speaker. Very excited to have him. Dr. Heung, are you there?
I'm here.
Fantastic. Thank you, Dr. Heung, for joining us. So I wanted to welcome everyone. I know that we have a lot of registrants who registered from all over the world. So we're going to give, about a minute or so just to let everybody get registered and sign in. And then we'll do a quick introduction, and then we'll get started with the webcast. So stay tuned. So Dr. Heung, how's the weather today over in Michigan?
It's pretty good. It's reasonably warm in the 70s, which is my preference. There was a big rainstorm yesterday, but that seems to have passed.
Nice. You guys had a tough football break this past weekend, didn't you?
Yeah, it was an interesting game, but a win is a win, and we have a bye week this weekend, so hopefully they can clean up the play and keep the winning record going.
Yeah, no, absolutely. Go Blue, right?
Go Blue.
All right. Give it a few more seconds and we can get started. Okay. So let me go through a little housekeeping. So again, hi everyone. Once again, if you're just signing in, my name is Omar Khatib. I'm the Director of Growth here at Potrero Medical. So Dr. Heung is on the line, and he's going to be giving us a fantastic presentation he actually did for our company when he visited about a month ago that you'll really find helpful on the current state of acute kidney injury as well as some future research and considerations. But let me give you a quick rundown of the console you have in front of you. So we use the On24 platform, which is a wonderful webcasting platform. And I just want to cover a few housekeeping items. So if you look at the bottom of your screen, you're going to see multiple application engagement tools that you can use. Now, all these engagement tools are resizable, and you can move them around. So feel free to move them however you'd like to get the most out of your desktop space. You can expand the slide area or maximize it so it's full screen just by clicking the arrows in the top right corner. Now, if you have any questions during the webcast, you can actually submit the questions in that Q&A engagement tool to the left of your screen. You'll see it right there. We try our best to answer these during the webcast, but if a fuller answer is needed or we run out of time, it'll be answered via email. But we do capture all questions, which leads me to my next point. We're going to have a live audience Q&A at the end of the presentation. So as you're watching the presentation, you see a slide, you have a question on it, go ahead and submit your question there. I would recommend submitting your questions early so that way they can get in queue and we're able to get to them. Now, Dr. Heung has been very gracious and kind to provide a copy of the slide deck that he's using today. So if you look at that green icon at the bottom, it's your resource list. You're going to find the slide deck there. We encourage you all to download the resources or links that you find helpful. And Dr. Heung actually did a podcast with us on acute kidney injury last year at the American Society of Nephrology, so you can check that out there. For the best viewing experience, we do recommend using a wired internet connection and close any programs or browser sessions that might be running in the background because that could cause issues. Webinars do have a large bandwidth, so closing unnecessary browser tabs will definitely help with that. The webcast is being streamed to your computer, so there's no dial-in number, as obviously. So for the best audio quality, just please make sure that your speakers and headset are turned up. Some networks may cause the slides to advance a little slowly than others, so don't worry about that. But sometimes logging off your VPN is definitely recommended. If your slides are behind, you can push F5 on your keyboard and it'll refresh the page. You can find additional answers or answers to your questions for common technical issues in the help engagement tool at the bottom of your screen. And lastly, an on-demand version of the webcast will be made about a few days after this webcast is done. So just check your emails. In a few days, you'll get a registration link to the on-demand recording, and you can share that with your peers and colleagues as well. So without further ado, let me introduce Dr. Michael Heung. Dr. Michael Heung is a professor and associate chief in nephrology over at the University of Michigan. I met him for the first time last year at my first American Society of Nephrology. We really hit it off. And of course, he is a fantastic person to follow on Twitter with one of my favorite nephrology Twitter handles, Keeping It Renal. So without further ado, Dr. Heung, the floor is yours.
Thank you very much, Omar, and thank you everybody for joining today. As you can see on the front slide, which will be also available in the packet, there's contact information there. So if you think of questions that you're interested in acute kidney injury even after today, you can certainly feel free to email me, or you can direct message me on Twitter, whatever your preferred contact platform is. And as you can see today, we're talking about acute kidney injury. This is my disclosure slide. I don't have any relevant financial disclosures to report, but in the interest of full disclosure, here's some of the grant funding I've received over the past 2 years, as well as my consultant roles. Real quick, I wanted to give a plug for the ASN Kidney Week Critical Care Nephrology Pre-Course. Sorry about my throat there for a second. The pre-course is on the Tuesday and Wednesday of Kidney Week, which this year will be November 4th and November 5th. For a full description of the course and as well as links to registration, you can go to the ASN website, which is asn-online.org. If you look under the Education tab, when you get this presentation email, the link is on this page as well. But it's a fantastic 2-day course. It's fairly jam-packed, but it's got a lot of leading experts in the world coming to speak about the very topic we're talking about today, AKI, as well as more broader topics within the realm of critical care nephrology. So I think I'm a little biased as the co-director, but it's been running for I think 5 to 7 years now, and routinely is one of the most popular pre-courses at ASN. So if you haven't had a chance to attend, and you have an interest in this area, it can be a very high yield way to get caught up in this field. So by way of outlining kind of objectives, I really was hoping to answer 4 questions today in this presentation. First, just to briefly get everybody on the same page by talking about what is AKI. And to do that, I'll be reviewing the definitions and their limitations and what might be changing in that area. Second, what is the impact of AKI? And we'll look at what the recent epidemiologic studies show and the overall scope of acute kidney injury. Describe the current standard of care for AKI. And then towards the latter half of the presentation, really talk about what is on the horizon, what are important recent advances, and the future, what potentially I think may be coming down the line that can change how we handle AKI. But first, what is AKI? Up until just over a decade ago, we used to call all of this acute renal failure, and it's basically defined as a sudden decline in kidney function. And I'll always remember my first attending just saying, you'll know it when you see it. Which is not a very helpful definition, especially from a research perspective. One of the important updates in the field was when Ravi Mehta from UCSD basically called out the fact that we really had no uniform definition. He published this paper in 2003, and I'm sorry, the picture doesn't show very well, but basically each line is a different definition for what we were all calling acute renal failure at the time. And as you can see, there are over 30 different definitions published in the literature, all varying in severity and just different criteria. And so he really helped the field move forward and say, we need to get on the same page and have some uniform definitions. So some updates from there. In 2004, the rifle criteria were developed. In 2007, the Accuryn criteria came out. And then in 2012, the KDIGO AKI definition came out in the AKI guidelines. Basically, this moved the definition so that as low as a 0.3 milligram per deciliter rise in creatinine met criteria for AKI. And as you can see, they're staging with stage 1, 2, and stage 3 AKI based on the degree of creatinine rise above baseline. Importantly, and sometimes overlooked on the right side here, you can see there was also urine output criteria put forward to define the different stages of AKI, and these urine output criteria do map to the same stages 1, 2, and 3. The urine output criteria is often overlooked just because we don't have hourly urine output for many patients with the push to get rid of catheters due to the concerns of catheter-associated urinary tract infections. But when you look at the urine output criteria here, you can see that they're potentially far more sensitive in that a decline in urine output for as little as 6 hours meets criteria for AKI. And in clinical medicine, we often don't recheck a creatinine that quickly. So I think recently there's been a little bit more interest in revisiting even the urine output criteria. But for most of the research in the literature, as we'll see, has used the creatinine-based criteria. Is everybody seeing the slide fully? Because my screen is a little, there we go, okay. So it's important to recognize what the limitations of the definition are as well. Current AKI diagnosis, again, relies on serum creatinine, which reflects a decrease in kidney function. So rather than just reflecting injury, it actually reflects the result of injury, which is a decrease in filtration and then the subsequent accumulation of creatinine. So therefore, it's somewhat insensitive to more milder injury. It is delayed, and again, it reflects a decrease in function. So looking at this figure, which shows the current paradigm of evolving injury, you can see that our current standard is identifying AKI when we've already had loss of kidney function. And in the field, we're very interested in moving away from that damage already done scenario to the earliest stages of damage when we think we could make a bigger difference potentially in intervention. So that might be our golden window. And as I'll talk about later on, I think recently we've moved even further to try to move backwards from even early damage into identifying the patients that are at risk and future AKI. Because, of course, if we can get into at that stage and prevent any damage, that would probably be associated with the best outcomes. So how are we doing that? There has been a lot of work over the past couple of decades looking for biomarkers of kidney injury, what we have termed the search for the renal troponin. Again, currently the standard relies on creatinine, which typically takes up to at least 24 to 48 hours to show us a significant rise. And as you can see from this figure on the left here, there's been a variety of novel biomarkers, including NGAL, both in the urine and plasma, and some other biomarkers that can be shown to be elevated much earlier on in the course of acute kidney injury, and actually potentially reflecting injury as opposed to just decline in function. And this has kind of resulted in a slight shift in the philosophy in the field, because now, traditionally, when we've looked at creatinine, we've been looking at damage with loss of function for creatinine rise. But going forward, it seems that we need to also look for evidence of biomarker damage. And if you look at this 2x2 table here, there is a scenario in the top right where the creatinine may not rise significantly, but there could be damage as it's picked up by these more sensitive biomarkers. So I think that is a very interesting category of acute kidney injury that's not really covered by our current definitions, but in the future may be an important target for interventions and I suspect in the near future will become more incorporated into the definitions for acute kidney injury. Now, what is the scope of acute kidney injury? This is one of the most common complications among hospitalized patients. This shows a study from using the KDIGO definition for acute kidney injury, so a consensus definition. One of the largest studies that was a meta-analysis of many other studies, over 3 million patients from around the world. And the pooled incidence was slightly more than 1 in 5 hospitalized patients affected by this. And you can see that the overall mortality among those patients was 23%. That's the figure on the left, so nearly 1 in 4. And you can see the figure on the right shows the odds of mortality when compared to no AKI. So if you had any AKI, you were 4.9 times more likely to die. And you can see that risk increased depending on the severity of acute kidney injury. And if you had the most severe form, which is requiring dialysis, you're 24 times more likely to die compared to not having any acute kidney injury. There was a sliver of good news in that study, in that the mortality rate did seem to decline over the study period. But clearly, the impact of this disease, of this condition, is very far-reaching and very significant. What about resource utilization? These are some older studies right now, but they still are relevant today. Acute kidney injury compared to no acute kidney injury is associated with increased hospital and specifically ICU lengths of stay. This has been shown in multiple studies in different countries and in different health systems and settings. And I haven't seen a lot of great absolute numbers, but when you combine the scope of, meaning how common acute kidney injury is with these increased lengths of stay, the mortality, the complications, the associated tests, this is clearly a billions of dollars issue. And beyond the short-term risk of death during hospitalization, there are significant long-term risks associated with acute kidney injury. And one of the best studied is what are kidney outcomes among patients who have AKI. This figure shows a meta-analysis that was published several years ago. And basically what it shows is that in patients who had acute kidney injury, the subsequent risk of developing chronic kidney disease was nearly 9 times higher. And similarly, for end-stage renal disease, you had significantly higher risk for developing that. And I've had the opportunity to work on this a little bit. This is a paper that we did several years ago now that looked at hospitalizations within the U.S. Veterans Association health system. It's a great database to work with when looking at AKI because there's actual clinical data. We actually have serum creatinine values and can apply KDIGO and consensus definitions for AKI and not rely on just diagnostic codes. And what we found was that when you look at the risk for subsequent chronic kidney disease among patients who did not have chronic kidney disease, even in the mildest stages of AKI, stage 1, you had basically a doubling of risk of subsequent chronic kidney disease. And this went up significantly with subsequent stage. So even among survivors of acute kidney injury, there are significant longer-term complications, and chief among those would be development or progression of chronic kidney disease. And basically, there have been continued unfortunate trends in severe AKI where it seems to be worsening. This is a study that's been quoted quite a bit that looked at hospitalizations and the risk of or the development of severe acute kidney injury between 2000 and 2009 in the U.S. And basically the figure on the left shows that there was a fairly steady increase, approximately 10% per year in severe dialysis requiring acute kidney injury. On the right, you can see that this is broken down by age group, and the rise was more pronounced in the older population, but it was basically seen across all age groups. So this is a fairly worrisome trend in terms of the overall impact, and that unfortunately, even with this very common condition, we've not been able to make a significant dent so far. But hopefully the tide is turning on that, and we'll talk about that a little bit later on. So just as an interim summary, AKI is a very common complication, increased mortality and morbidity both in the short and longer term. It's an important gateway to chronic kidney disease, meaning it can be the first mechanism by which people have a decline in kidney function that persists or progresses. It looks like it's getting worse. And so what is the current state of the art to tackle this major public health issue? Unfortunately, we don't have a lot of tools in our tool belt for acute kidney injury. This is a snapshot of some of the recommendations from the published KDIGO AKI guidelines that came out in 2012, which is still the most recent set of guidelines from them. And what you notice here is that there's a lot of what doesn't seem to be helpful. All of these are recommendations that were based off of clinical trials that have tried to look at agents such as diuretics or dopamine, phenoldiazepam, others, to try to either prevent or treat established acute kidney injury. And as you can see from these recommendations, the vast majority of these trials were negative. And so when I talk to my medical students and residents, unfortunately, at this point, I basically have to say that there's not really any medical therapy that's been proven to decrease mortality, reduce likelihood of dialysis or duration of dialysis, or even enhance recovery in established severe AKI. And so the care of these patients remains primarily supportive. So from my perspective, that means that we need to have strong efforts at prevention. To that end, one of the things that's developed over the last several years has been the first biomarker approved in the U.S. This is two markers of cell cycle arrest, urinary tissue inhibitor of metalloproteinases 2, and insulin-like growth factor binding protein 7, which are marketed under the name NephroCheck in the U.S. Basically, they are markers of cell cycle arrest and presumed to reflect the kidney's response to injury or stress. And so they were identified in various cohort studies and then subsequently validated in a couple of observational studies to predict moderate to severe, in other words, stage 2 to 3 AKI within the subsequent 12 hours in critically ill patients. And so they've been approved for use in the U.S. for about 5 years now. The test characteristics are pretty decent. It has a fairly good sensitivity, although a low specificity. In the overall AUC is about 0.82. And importantly, the performance was stable across comorbid conditions, including chronic kidney disease and diabetes, which are, of course, two high-risk populations for acute kidney injury. So now what? So now we have this test that can predict future risk. And I will tell you that we didn't immediately try to get this test available at our hospital because that was the exact question we had. So if we had this test available to, predict future risk, what would we be able to do with it? Would it actually make a difference? What would be the tools that we have? Well, fortunately, other people are asking the same question, and a couple of studies have come out in recent years that have really tried to answer that. One of them is the Big Pack study that was published a couple of years ago, a study in Germany that basically took patients undergoing major non-cardiac surgery, and they used the biomarker to identify high-risk cohorts. So in other words, people came out of surgery, they got this test. If the test was above the threshold of 0.3, then they were considered to be high risk, and then they were randomized in the study to usual versus bundled care. And what they were able to show is that with nearly 40% or over 40% reduction in any acute kidney injury. And if they looked at specifically a moderate to severe stage 2 to 3 acute kidney injury, they decreased that by nearly 2/3. So those are fantastic, really fantastic outcomes for such a common and significant condition. They also were able to show an overall significant decrease ICU length of stay among the patients who had the bundled care compared to the usual standards. So they were really able to make a dent here. And this has led some people to say this is a editorial from John Kellum, who's one of the leaders in the field, stating, AKI, the myth of inevitability is finally shattered. So what I said earlier about, not having any treatments or anything like that, for severe AKI, well, maybe we finally have a little bit more of a blueprint for how to head it off in the first place. So let's take a little bit of closer look at what they actually did as part of their bundle. What was the actual intervention? It wasn't anything novel. There weren't any magic bullets. There was an emphasis on volume therapy to make sure people had adequate resuscitation if needed. And they did have some toys like looking at stroke volume variation, IVC collapse, or IVC diameter, and other tools. But generally speaking, it was fairly basic principles, and they targeted a blood pressure. One other important part of the bundle was nephrology consultation at the time of randomization. And obviously, I'm a little biased here, and you can see my weekend uniform over there in the picture. But basically, the nephrologist was there to help monitor for nephrotoxic exposures, to help adjust medications, and to help try to make sure that we were doing everything to protect the kidneys in patients that seemed to be at risk. And as you saw from the results on the previous slide, this overall bundle was highly effective. So I wanted to shift to the last part of this presentation to talk about what potentially is on the horizon for management of acute kidney injury in the field as a whole. I'm going to briefly talk about how I think we're going to see a better understanding of AKI's pathophysiology and hopefully leading to newer therapies. Talk about the role of AKI risk prediction, and then finally some emphasis on secondary prevention, since we won't be able to prevent every case of AKI. One of the areas that has not been had much attention so far has been trying to look for genetic risk for acute kidney injury, especially with the use of unbiased approaches such as genome-wide association studies. The use of an unbiased approach can be helpful because you can identify connections with genes that may not have otherwise been known to be associated with acute kidney injury. And this model has been seen in a variety of different diseases. Probably the most famous example would be age-related macular degeneration, where a genome-wide association was able to identify a very strong signal from the gene for complement factor H. And at that time, complement was not even recognized as part of the pathophysiology for age-related macular degeneration. And subsequent studies to follow up on that have shown what the connection is. And just in recent years, there are now targeted therapies in clinical trials looking at that. But that connection was only identified through some of these genetic studies. And so we're starting to see some of that in acute kidney injury. There have been just a handful of genome-wide association studies done, and one of the largest was able to identify 38 single nucleotide polymorphisms on 18 different genetic loci. And what's interesting is that these aren't all risk. Some of them were risk, 18 of them were risk, but 20 were protective as well. So again, from both angles, there could be opportunities to better understand what goes on in the acute phase of development of AKI, as well as the evolution of AKI and maybe even recovery of AKI. And these signals may lead to targets both to reduce risk and to counsel patients for risk, but also maybe to direct measures at how to be more protective against kidney injury. I have the opportunity to work with a group at Michigan called the Multicenter Perioperative Outcomes Group, or MPOG, and we have recently done our own GWAS, which is looking at a number of patients post-surgery, and we also have preliminarily identified some findings in the dopamine receptor, and obviously dopamine has influence on renal flow, so we're interested in exploring that signal a little bit more in the future. But again, these studies are meant to help identify new areas to look at. They in themselves are not going to be conclusive. We still need to look at areas to identify potential future targets for therapy. Shifting gears a little bit, another important area that I think is ongoing and could be part of our routine care, hopefully in the near future, is the use of data analytics and trying to predict AKI. My good friend Jay Coyner in Chicago has been doing some great work in this area. He used their data at the University of Chicago to develop a risk prediction model using machine learning approaches to subsequently predict the risk of acute kidney injury. This is a table. This is a big long table just showing all the different variables that they put into their machine models. We're not meant to look at all these things, but the things I wanted to circle and point out were that in addition to static variables like demographics and things, they really applied a clinical lens to this and used dynamic variables such as trends. So changes in vital signs, for example, changes in labs, which is, of course, how when we are clinically taking care of patients, we often take those things into account. And so they applied that kind of dynamic approach to their model as well, whereas most models in the past have been relatively static, looking at baseline variables. And what they found were fairly excellent test characteristics from the models they were able to develop. And if you look in the box, the red box, you can see that they had AUCs for their model in the 0.93 to 97 range, especially for more severe AKI. But one of the challenges, I think, with AKI prediction is making sure that it is there's high clinical utility. And, with the best AUC, you can see that here in the red box, the probability cutoff there was only 2.2%, and the positive predictive value from the test was only 10.4%. So that brings up some of the concerns about nuisance alarms and things like that, because those of us that are clinicians and working with the electronic health record every day are, often feel bombarded by different alerts coming up, and there can be a situation of, the boy crying wolf kind of situation where, alarms that don't actually lead to anything or mean anything, pretty soon we start disregarding all of those alarms. So I think, one of the areas that needs further work in terms of AKI prediction is to hone the risk prediction to make it friendly to practitioners. Jay is not the only one who's been working on this. There are several other groups. In fact, my group at Michigan is working on a project with the VA. And some of you may have seen this recently published just a little over a month ago, a paper from Google and DeepMind, where they took VA data and they used deep learning approaches to try to predict AKI within the next 48 hours. And if you look at this figure on the right, on the bottom, it shows the risk according to the model with the orange line as the threshold. And you can see where that green line crossed the orange threshold. And if you then move up to the pane, the figure A, you see that threshold was actually hit, and therefore an alarm sent before there was ever a rise in the creatinine. And it was not until 48 hours later that the creatinine actually rose enough to meet the threshold of criteria for AKI. So they were able to identify 56% of all AKI cases up to 48 hours in advance. And just like in the previous study, they had even better prediction for the more severe cases. But there still remain some risks here. They had a 1 to 2 true to false alerts. So for every true alert where somebody was going to develop AKI, there were 2 basically false alarms. And so once again, that brings up the concerns about how usable these tests are in clinical practice. And I do think that they addressed that with looking at this figure, trying to do some variation in terms of the sensitivity of the model and specificity to balance in terms of the precision versus actual sensitivity of the test. So I think that is the kind of work that needs to be done to better hone models, to find a balance in identifying enough cases, but also limiting the number of false negatives so that we don't have too many nuisance alarms. So again, challenges to AKI prediction. There is inherent heterogeneity of AKI. We have to balance that sensitivity versus nuisance. And then also, once you identify an alert, that alone is not enough. We need to have some appropriate clinical decision support. We need to guide the clinicians how to then head this off. And I think these need to be flexible as things move forward. And luckily, there are a number of clinical trials working in this area. So I do think predictive analytics will be a really important part of AKI management in the future. But we're not going to be able to prevent every case of AKI. And so there's a role for secondary prevention as well. And there have been a couple of interesting studies in recent years that have shown some promise there. This study was a basic study in animals, in rats, where they had a model of acute kidney injury. And by giving medication spironolactone, which we use clinically and has been shown to help with decreasing fibrotic changes, they were actually able to show less subsequent kidney injury and less permanent damage when in the animals that got the spironolactone versus did not. You can see the histologic pictures on the right. Basically, red reflects scarring and fibrotic changes, permanent damage. You can see in pains A and B, where they did not get spironolactone, there's a significant amount of red reflecting the damage and inflammation after acute kidney injury, whereas there's relatively preserved architecture in pains C and D, where the rats did get spironolactone. So I think this is pretty exciting because, again, if we can prevent some of the long-term damage, that has a potential huge clinical benefit in attenuating the negative impact of acute kidney injury. And there are some clinical trials looking at this, so hopefully we'll see some more results looking at this. Another study that came out just recently looked at the role of vitamin D3. What's been known is that the molecule NAD+ seems to be protective in many processes, and what they found was that in this case, it may play a role in ischemic acute kidney injury. They found lower levels of NAD. And so what they did was, you can see that in this pain, there's a couple of different pathways to NAD formation. On the left is the tryptophan pathway with an enzyme QPRT. And what they found was that in mice who have a QPRT deficiency, they did have a higher AKI risk, which again further supported the role of NAD as a potential protective factor. And even more importantly, that risk, when they gave NAM, which is nicotinamide, or vitamin B3, which on the right box is a part of the salvage pathway, they were able to increase the NAD and decrease the AKI risk in those mice with the QPRT deficiency. So this was some proof of principle, both that NAD may play a role and also suggesting that nicotinamide may be of therapeutic benefit. And so in this paper, they actually went farther and they did a phase 1 randomized controlled trial in patients undergoing cardiac surgery where they gave them high-dose nicotinamide And basically, they were able to show that this led to higher levels, so there was some proof of principle that it was effective in getting converted. And I think somewhat surprisingly, they were also able to show that it seemed to lower AKI risk, even in this small study of just 55 patients. And that's shown in the graph that's labeled I here on the left and the. So basically, the creatinine levels were lower in patients that got nicotinamide. So obviously, more work needs to be done here, but this is, I think, fairly exciting, an example of understanding some of the pathophysiologic mechanisms in AKI, and hopefully that leading to novel therapies. And so I do think that the tide is turning on this. Some of the studies I just showed, but also the recent executive order that probably all of you have heard about in July called the Advancing American Kidney Health. Some people think that this may be the biggest legislative move since the CMS amendment, the Medicare amendment to have ESRD coverage for under Medicare. The stated goals of this executive order are, as you can see here, and what I really just want to focus on is that that first goal, which is to reduce overall end-stage renal disease. So we're going to hopefully see a lot more resources poured into this, and specifically stating support for research on kidney disease prevention. And even though acute kidney injury isn't specifically mentioned in this, as hopefully we saw earlier, acute kidney injury is one of those important gateway diseases. So I'm hoping this will further spur some more research and innovation in the area of acute kidney injury as well. So just to summarize, AKI is one of the most common complications among hospitalized patients, and it's a major significant risk factor for both short-term mortality and longer-term outcomes, including kidney outcomes, cardiovascular outcomes. It really has a major public health impact. And this is not just in the U.S., but really around the world. Unfortunately, there's no real proven effective medical therapies once you have established severe AKI, but we're starting to see that in milder stages of AKI, we may be able to attenuate worsening, and hopefully we can start to prevent some of the complications of AKI. So I'm hopeful for the future with acute kidney injury. I think there have been a lot of interesting outcomes recently, and I do think over the next decade we're going to see some further transformation in how we manage AKI. And hopefully I won't be saying anymore that we don't have any proven effective therapies. So thank you very much for attending this webcast today, and I just wanted to mention again the critical care nephrology pre-course at ASN for those of you that are particularly interested in this area and looking to learn more. Thank you.
Fantastic, Dr. Heung. Thank you. Wonderful overview of AKI, and thank you all for attending now. We are going to jump right into the live Q&A session. We got some questions that are coming in, so I'm just going to remind all the attendees, if you look, and even if you're not watching this live, you're watching the recorded version, you can actually still submit questions on demand. It'll just go to an email and we'll be able to answer it in a timely fashion. But go ahead and look to your left or down below and click that Q&A box. Go ahead and submit your questions. We'll give a few seconds for people to get more of the questions in. But Dr. Heung, just out of curiosity, can you share, especially for some of the physicians who are either watching this live or on demand, a little more about the critical care nephrology pre-course at ASN that you lead?
Sure. It's a 2-day course again, and it's pretty full days. And we have lectures that are anywhere from 30 to 60 minutes. We try to keep them interactive and emphasize as much audience participation as possible. One day focuses more on general critical care topics that are relevant to nephrologists. For example, we have some talks about fluid resuscitation, vasopressor use. We have a special session this year with somebody coming to talk about ECMO. Many of us that consult at medical centers where there's ECMO often need to interact with those folks and make sure that our machines play well together, for example. So there's a lot of sessions covering broader critical care topics that are relevant. And then the next day is really more focused on the kidneys with acute kidney injury and some very practical aspects of acute dialysis, including a great session that is done by Ashita Talwani, who is at UAB and my co-director for this course. She gets a wonderful talk about CRRT prescription and what are the different issues that people frequently encounter around continuous renal replacement therapy. So it's got a lot of very practical knowledge that you can take home with you to your practice. We do emphasize, standards of care as well as, what is up and coming. So it's a nice way to refresh if you already are an expert in this area. I learn a lot every year from this course. But even if you're relatively new and just interested in the area, it's a great way to kind of get up to speed on what are the prevailing thoughts on these different areas in the field.
Nice. Fantastic. I think I know a lot of people are really looking forward to that. So let's jump into a couple questions. So we have one question coming from David. David, thanks for your question. The question is, what has been your experience with the biomarker NGAL and using RAI model?
So the NGAL is not actually approved for clinical use in the U.S., so I don't have any clinical experience with NGAL. The RAI, the renal angina index, is, I think that's a great model to use in terms of, again, going to that concept of risk prediction. Can we identify patients that are at risk for moving into acute kidney injury and therefore manage them in that golden hour, if you will, or golden period when hopefully we can head off injury. So I think it's very much in line with the predictive analytic models that I talked about using clinical data. I do think the use of incorporating biomarkers in the future will be an important role for that, but I can't say that I have any specific personal clinical experience with them at this point.
All right, next question. Let's see. I got quite a few that came in. Let's see if we can get a good one here. Oh, this is a nice one. So Sally, nurse from Nebraska, said, "Excellent presentation!" Exclamation marks. Thank you, Sally. Where does accurate urine output data fit into early detection for AKI and management of a patient?
Yeah, thanks for that question, and thanks for the kind comment, Sally. I think, urine, as I mentioned earlier, urine output is almost like the forgotten criteria for acute kidney injury. And it arguably is the most sensitive and earliest way to identify acute kidney injury. So I think it's one of those, like old is new again, and we've moved away from urine output into these fancy biomarkers and other things. In recent years, I've heard more talks at conferences trying to get us back to focusing on the urine output. But as I mentioned, some of the challenges are that it's hard to get hourly urine output. There's a significant workload for the nurses to have to go and measure it. There are potential significant issues with accuracy of urine output depending on the indwelling Foley catheter device. And quite frankly, I don't disagree, but we've moved away from having catheters in place for the risk of the catheter-associated UTIs, which I think is appropriate, but obviously then makes it basically impossible to assess hourly urine output for this. So I think it's important in our hospital system. in some of our ICUs, especially the surgical ICUs, we do have very good hourly urine output monitoring, and it has been part of our early alert system to get people involved, including nephrology, ahead of traditional markers such as waiting for the creatinine to rise. So.
Wonderful. Thank you for diving into that. So, Dr. Heung, let me ask you. So it seems, we've seen, so of course, there's a company like Potrero who's looking into AKI and of course the use of urine output. We have Google who published that study looking into more, as an EMR crawler on the lab results side. So it seems like for the first time, nephrologists are starting to get better tools and technology to start moving more upstream, so that way they're not, the patients aren't coming to them with chronic kidney failure, and that way the nephrologists are being brought in almost more like an interventional role. Can you talk a little bit more about that and sort of the role of the new role that nephrologists are starting to step into in the hospital?
Yeah, I would. Unfortunately, it's more still a hope than a reality at this point. But I think that as a nephrologist, a lot of times I'm called in to help rescue the situation. And by that I mean I'm called in when somebody has pretty severe renal failure and basically needs dialysis. And that's kind of frustrating. I mean, it's great that we have dialysis technology and we can come in and help support these patients, hopefully through to their recovery. But as I showed in some of the studies, I think there's increasingly a recognition of a role for prevention. That doesn't have to be a nephrologist, and realistically, I don't think there's enough nephrologists to go around to try to prevent AKI in every patient that's high risk. But hopefully, with some of the studies that have come out, there will be increasing awareness, and hopefully nephrologists can be part of the educational program to help other services recognize the patients that are highest risk and what to do. There's some studies out there that have suggested that, as much as 20 to 40% of AKI episodes could have been prevented. And obviously, when you look back with the retrospective scope, you can always see, oh, yeah, maybe we shouldn't have done that CAT scan or that with contrast or given this medicine. And so, it can be a little bit unfair to, in hindsight, say that. But nonetheless, I think there are clear opportunities there in a prospective way to try to limit kidney injury in patients that are recognized to be high risk. But first, they have to be recognized to be high risk. And again, maybe biomarkers will help with this, as shown in that big tech study I showed. And I think certainly predictive analytics can help with this. And we've already seen this in other settings, such as sepsis, with computer alerts identifying patients as potentially moving into early sepsis and activating, teams to help head that off. I could certainly see that being part of what happens with patients at risk for acute kidney injury. I mean, you're talking about a condition that has high mortality that occurs in up to 1 in 5 hospitalized patients. So I think there's pretty significant impact there and role for future novel interventional programs.
Fantastic. Another question. This is more on the executive order that came out of the White House for kidney health. The question is, what did you think about it, and is AKI involved in that executive order?
Yeah, so I'm excited about it. Nephrology has sort of been the forgotten field. There are some statistics that have come out recently that show that funding for kidney disease related research is like a tiny fraction relative to other specialties, especially when you account for the relative impact and how much we spend on actual kidney disease in this country. So I think it's far overdue. Obviously, I'm slightly biased, but I think it's far overdue to have more attention on improving kidney health and preventative care. and I hope that this will help bridge that gap a little bit. And if people weren't aware, funny story, this is kind of how things happen. One of the reasons this finally got on the radar is because, the director of the Secretary of Health, I think, Alex Azar, his father is a dialysis patient and got a transplant. So he knew firsthand how significant an issue this is and was able to push this agenda forward. So I'm excited for it overall. There's a lot of details that need to be worked out. I think the goals are extremely ambitious, but hey, if this is going to be our kidney moonshot, then let's go for it. And even if we accomplish half of those goals, that will be a huge improvement. And as for specifically AKI, no, I did not see anything in there specifically around AKI, but I think that increased kind of ancillary funding for things like kidney prevention or kidney disease prevention, ESRD prevention, acute kidney injury certainly will fall under that umbrella, and I expect to see some extra resources looking at that angle as well.
Fantastic. And, we're getting close to time, so we want to be mindful of it. So a couple more questions. So one quick, interesting one. I think it's a great question, actually, because this is something that I think more people need to know more about. But we have a question from Lawan that says, what is your recommendations for having a healthy kidney? I think that's a pretty good one, actually.
For maintaining a healthy kidney?
Yes.
Is that the question?
That is the question.
Yeah, no, I honestly, I think that anything that is just part of a healthy lifestyle is going to be important for the kidney. I think that for most of us, as long as you're drinking adequate amounts of fluid, you're not constantly dehydrated. I'm not a big believer in terms of like a set amount of water. I think that there's not good studies to support that recommendation you hear sometimes out there, 64 ounces of water a day. In patients with kidney disease, that can actually be dangerous. But at the same time, people who constantly run dehydrated, there probably can be some stress. There's some actually interesting studies that look at kidney disease epidemics in some equatorial countries where you have people like sugarcane workers have a huge load of kidney disease, and it's thought to be related to heat stress and simply lack of hydration. At least that's one of the theories. So for most people that aren't in that situation, I don't think there's a special amount of water to drink. But basically, healthy habits. If you look at the biggest risk factors for kidney disease, diabetes, so maintaining a healthy weight, eating well, exercising. Hypertension is another leading cause. Maintaining good blood pressure, managing high blood pressure if you have it, watching the sodium, the salt in your diet, and honestly, anything that is heart healthy, because we know that patients who have heart disease are at significant risk for kidney disease, and vice versa. So I think that really a general healthy approach, and when you think about it, the kidney plays such an important role in maintaining balance throughout the body. It makes sense that general healthy measures for the body would be protective for the kidney. So I hope that's not too vague, but that's honestly, how I view it.
No, not at all. Not at all. And then I guess, so last question. This is an interesting one. So kind of a long one, so I'm going to try and summarize this. So the question is around cardiac surgery, and that AKI is high, or it's very common with patients who have cardiac surgery. But for anesthesiologists in these cases, they're still using things like a Foley in a bag. And the question is the management of urine output going to be more important in cases like this, especially considering that the patients are having ECMO and they're having fluids pumped into them, how important is urine output measurement in these type of cases with patients undergoing cardiac surgery?
Yeah, so cardiac surgery is absolutely one of the highest risk conditions just because of the cardiopulmonary bypass. And it's probably the best studied situation or condition, if you will, for acute kidney injury, just because presumably you know when the injury is occurring, which is during the surgery. So specifically regarding the urine output question, most of our patients who come out of the operating room after cardiac surgery do have a Foley catheter in place to measure urine output. And again, the urine output arguably is going to be one of your most sensitive factors, because our patients that come out of the operating room may have labs right away, but they may not have time to reflect kidney injury simply because the creatinine may not have had a chance to rise yet. And then the creatinine may not be checked again until the next day, almost 24 hours later. Whereas, and so that would be the next earliest point potentially to identify significant kidney injury in patients. But arguably, if in the meantime, in those 24 hours, you see a declining urine output, a low urine output, or obviously no urine output, you can make the diagnosis of not just stage 1 AKI, but even more severe AKI well before that. So, yeah, as simple a biomarker as urine output is, it's still a very important one. It's one that we certainly pay close attention to still, and arguably, again, it's an earlier signal than creatinine for sure, and probably more sensitive as well.
Fantastic. Well, we are over time. I want to thank all the attendees for getting registered and joining. And if you're not joining us live, that's okay. Again, you can submit your questions on demand in the Q&A, including all the live attendees. If you decide to watch this again, which I definitely recommend you do, feel free to submit those questions in the Q&A box. Dr. Heung, can't thank you enough for taking time to join us and educate us all on this major global threat to patients and really doing service to your peers to get everybody caught up to speed with it.
Yep, thank you for having me, and thanks everybody for attending.
All right, everyone, take care, have a great day, and enjoy your weekends.